Neurology Quiz number 37. Describe pathogenesis, clinical features, and treatment of cluster headache. Cluster headache is the most common of the trigeminal autonomic cephalgias. The underlying pathophysiology is related to hypothalamic dysfunction and its connections with the cranial autonomic and trigeminovascular system. It is more common in men. Male-female ratio is 2 to 3:1. The sex difference is not as great as was previously thought. Typical age of onset is 20 to 40 years. Two types are described: episodic, headache-free periods between cycles are more than 3 months, and chronic, headache-free periods between cycles are less than 3 months. 90% have the episodic type, but up to 30% of patients can change from episodic to chronic and vice versa. Episodic version typically has 1 to 2 headache cycles per year, with each headache cycle lasting 6 to 12 weeks. It is characterized by unilateral severe or very severe orbital/supraorbital/temporal pain, usually side-locked, lasting 15 to 180 minutes when untreated. It is accompanied by restlessness, agitation, and/or ipsilateral cranial autonomic features such as conjunctival injection, lacrimation, nasal congestion, rhinorrhea, eyelid edema, forehead and face sweating, and miosis and ptosis. Typically, patients have 1 to 3 attacks per day lasting 45 to 90 minutes, but frequency varies from 1 every other day to 8 per day. Circadian pattern is characteristic, with headaches occurring at defined times of the night. Precipitating factors include alcohol, heat, exercise, high altitude, nitroglycerin, and strong odors such as cigarette smoke or solvents. This figure shows autonomic signs during cluster headache with partial Horner's syndrome, conjunctival injection, lacrimation, and rhinorrhea on the left. There is associated periorbital edema. Postulated mechanism for cluster headache. 1. Anterior hypothalamus generates the headache and is also responsible for diurnal fluctuation. 2. Pain of cluster headache is mediated by ophthalmic division of cranial nerve 5, which becomes activated, associated with increased levels of CGRP, VIP, etc. 3. Parasympathetic fibers from cranial nerve 7 end in sphenopalatine ganglion. Postganglionic fibers project to the lacrimal glands, blood vessels, and meninges. Hypothesize that activation of trigeminal nucleus activates these fibers, causing lacrimation, rhinorrhea, conjunctival injection, etc. 4. Oculosympathetic failure with ptosis miosis is thought to result from stretching of these fibers in the adventitia of the internal carotid artery, secondary to vasodilatation. Treatment is acute, transitional, and prophylactic. Acute treatment: subcutaneous sumatriptan is the only FDA-approved treatment for acute management of cluster headache. Dose is 4 to 6 milligrams with a maximum of 12 milligrams in 24 hours. Another effective treatment is high-flow 100% oxygen administered via a non-rebreather mask at 12 to 15 liters per minute for 15 minutes and used several times before being discarded as ineffective. Other evidence-based therapies are intranasal sumatriptan, zolmitriptan, DHE, lidocaine, and IBIM-DHE. Non-invasive VNS is also FDA approved for treating episodic cluster headache in adults. Oxygen and VNS can be suitable options for patients with contraindications to or with a high triptan requirement. Oxygen and intranasal lidocaine can be used in pregnant patients. The figure on the left shows a non-rebreather mask. Oxygen should not be given through a nasal cannula but through the mask, which is the most effective way of giving high concentration, high flow oxygen. The figure on the right shows a non-invasive vagus nerve stimulator. Transitional treatment. These treatments are preventive but can be up-titrated quickly and are used for short periods. A common regimen is oral prednisone starting at 100 milligrams per day and tapering over 3 weeks. IV steroid boluses have also been used. Greater occipital nerve block can be used as transitional treatment. Preventive treatment. Evidence-based treatments of choice for cluster headache prevention are verapamil and lithium. For verapamil, starting dose is 40 to 80 milligrams TID, escalated rapidly as tolerated to effect, and required daily doses for relief can be 400 milligrams per day or higher. Baseline EKG and follow-up EKG for monitoring of AV block is recommended. Dose of lithium is 600 to 1200 milligrams per day. Galcanezumab, a CGRP antagonist, is FDA approved for treatment of episodic cluster headache. Non-invasive VNS has also been FDA approved as an adjunct preventive treatment for cluster headache. Sphenopalatine ganglion block may be beneficial. Sphenopalatine ganglion stimulator is not used in the US, although it has been used in Europe. There is anecdotal evidence for use of topiramate, gabapentin, and sodium valproate, as well as melatonin. ICHD 3 diagnostic criteria for cluster headache are given below.